Right, good afternoon, everyone. Thank you for making time to join us this afternoon. This is Dr. Veronica Jawale, representing the Center for Biomedical and Minority Health Research, the Community Engagement Core here at Texas Southern University. And this afternoon, it is our pleasure to bring you our health education seminar, which will be focusing on diabetes. Just a little bit about ourselves. The Community Engagement Core of Texas Southern University's Center for Biomedical and Minority Health Research. That's who we are. And our goal is to be able to work directly with the Greater Houston community members so that we can identify and address health-related concerns and also be able to provide health-related resources to the community members. And the way that we do this is we work closely in partnership with healthcare systems in the Texas Medical Center area. We work with federally qualified healthcare centers, as well as community and faith-based organizations. We host health education events across the Greater Houston community with the intention to increase information about health awareness on diverse topics and also to increase clinical trial awareness and reduce health disparities among ethnic minority community. For more information about programs that we'll be having in Community Engagement Core, feel free to visit us on all our social media outlets on Instagram, Facebook, Twitter. Join us, follow, like, and share our pages. And you can find us at CECTX Southern, or you can also give us a call, 713-313-1986. Feel free to also send us emails. Our email address is cbmhrcommunity@tsu.edu. Also, we want to appreciate the NIH because this is the funding agency that provided funds to support today's program to be able to implement our center, the Center for Biomedical and Minority Health Research, funded by NIH Research Center for Minority Institution Programs under the U54 MD007605 grant mechanism. For today's program, we also have our partnering institution, Aging and Intergenerational Resources, has partnered with us to be able to support the program. So we want to thank them along with all our partnering institutions, community organizations, as well as faith-based. Just a couple of announcements for everyone. Again, I want to thank you for joining in this afternoon. Please remember to remain muted throughout the course of the presentation. There will be time for questions and answer at the end of the session, and you can also post your questions in the Q&A box. So there is going to be a Q&A box to the bottom of your screen, so feel free to post your questions there, and we will answer those questions as we go along through today's presentation. Also, at the end of the presentation, we would love to hear back from you, our wonderful participants in today's event. So we will be posting the link for our survey in the chat box. So please click on that link and complete the survey. And there is a giveaway of $10 Target gift card for the first 10 attendees that complete that survey. So please take a moment of your time to provide us with valuable feedback on our event today. Also, to inform you of our upcoming health seminars. So in January 2021 as well as February 2021, we are still focusing on diabetes. But in January, we will talk about self-care and resources for people living with diabetes and their caregivers. And in February, we will talk about preventative measures in diabetes. So at this point, it is my pleasure to bring up our very own speaker, Dr. Adlia Ebeid. Dr. Adlia Ebeid currently serves as the Director of Pharmacy Services at San Jose Clinic. She's been there for over 5 years, and she has more than 15 years experience in pharmacy services with specific expertise in chronic disease state management and patient safety. She enjoys patient care and empowering others to learn about their medications and focusing on self-care. Dr. Ebeid, thank you for joining us this afternoon, and I will turn it over to you for the presentation. Thank you.
Thank you so much, Dr. Arjual. I'm going to share my screen with everyone so we can launch the presentation. Okay, I hope everyone is able to see the presentation. I want to say thank you so much for having me here to speak today. Like Dr. Arjual mentioned, my name is Adlia Ebeid, and I am the pharmacy director at San Jose Clinic. I'm actually also board certified in diabetes management, and diabetes holds a very special part in my personal and my professional life. So I feel very privileged to be here today and to speak to all of you regarding something that has impacted my life, both personally and professionally. And we'll get a little bit into all of that as we proceed with the presentation. Thank you to the Center for Biomedical and Minority Health Research and this program for allowing me to come and speak to you. I have no disclosures to disclose at this time. So this is just a general outline of things that we will kind of go over today. It's really important to understand the disease, the diabetes, to kind of understand where the medications are coming from and what our goal is to keep you all healthy. Treatment is a big part of my presentation because I am going to focus on the medications. We'll talk a lot, we'll talk in a lot of detail about the medications and kind of give you some pointers that hopefully will help you to lead healthier lives. I will go over some patient stories. Seems like every time I include patient stories in my presentations, it helps everybody realize they're not alone and it makes it more real. And so I like to always include patient stories so you can understand kind of the patients I serve and the encounters I've had that have led me to be so passionate about diabetes management. Talk about goals of therapy. We'll touch a little bit on self-care. I'm very glad to see there's another presentation in January on self-care, so it'll nicely tie into this. And then we'll just leave you guys with some things to remember. If you have any questions at any time, please feel free to put them in the chat, and we will address all those questions at the end of the presentation. So without further ado, we will begin. Understanding diabetes. So a little bit of background about diabetes, because there are two major kinds of diabetes. We have type 1 diabetes, where the body just does not produce enough insulin. And those patients account for about 5 to 10% of all of the diabetics that are in the world. And usually it's diagnosed early on, maybe 13, 14 at the latest, when you realize that something is just not working right in your body. And type 2 diabetes, however, is much later onset. It's where the body produces insulin, but it just can't use it as well. And there could be some deficiencies in the production or other parts that's making the body just not able to conquer the diabetes. This accounts for 90 to 95% of all adults that are diagnosed with diabetes. And so it is the majority, and it's kind of our focus for today. I will be happy to entertain questions also on type 1 diabetes, but I did really focus on type 2 diabetes in this presentation. There's a lot of aspects that are included in type 1 that just don't apply to type 2, but I'd be happy to answer any of those questions at the end of the presentation as well. So right off the bat, you see it in big lettering right there. 1.5 million people will be diagnosed with diabetes this year. And I put that out there for many reasons. It's really, really important to understand the impact this disease has on our population. You're currently in a situation, you've been diagnosed with diabetes, but you're also tasked with being the advocate to help prevent other people from getting diabetes, or at the very least, delay the onset. So whether it's your children, your siblings, your parents, once you get diabetes, you almost become like this knowledgeable, almost like you're like the doctor, all the stuff that's happening, you understand the disease, you understand the medications. So we really want to empower our patients to be those advocates in their communities to help people either, like I said, delay the onset of diabetes or try not to get it at all, because 1.5 million people will be diagnosed with diabetes this year. And so 34.2 million people have diabetes in the United States. That's about 1 in every 10. So chances are at least 1 or 2 other people who have diabetes. They may or may not be in your family. But here's the other thing. 1 in 5 people have diabetes but don't even know it. Again, this is where you can really help become an advocate for the disease and raise awareness and help educate those that you interact with to see if that's something that could be possible, because the quicker we know, the better it is, the easier it is to manage, and then the complications, which we'll talk about later, will be so much more delayed. So it's very, very critical for us to know if people have diabetes as soon as they were able to. The earlier, the better. That's 88 million people. 88 million people, which is 1 out of every 3 have prediabetes. And so prediabetes is that precursor, that we're hoping it doesn't lead to diabetes. We know it inevitably will, but there are some things that we can do early on in prediabetes, again, to delay the onset of the disease. But 34.2 million people, I also put it out there to all of you guys to tell you that you're in good company and that this is a very manageable disease. The complications are very preventable, but I can't do it by myself. Your doctors can't do it by themselves. Your pharmacists can't do it by themselves. We really want to empower you to take control of your diabetes so that you can take care of yourself, and we will guide you through each step of the way. So I talked a little bit about the complications of diabetes. And so for people who have uncontrolled diabetes, or they let it go on and prolong without taking care of themselves, this is what we end up seeing. And I say these are preventable, and I mean it 100%. If we're able to catch diabetes early on and manage it and keep it under control, the likelihood that these complications will occur is drastically reduced. And big things like heart attacks, strokes, neuropathy, which is really bad nerve damage that can lead to, if you get a cut or something on your foot, or if you step on something, you don't feel it, then it gets infected, and that can lead to amputations. Kidney disease is a major complication. It ends up having patients end up on dialysis, which is not fun for anyone. Blindness, there are people who get glaucoma and then cataracts and they can't see. There are so many complications of diabetes, and we've learned that the tighter we manage and control the diabetes, the less likely that we will have these complications in the future, or even as severe as they could be. So if uncontrolled, though, the likelihood of having diabetes, having these complications from diabetes is very high, highly likely. And I say this to say, 20, 30 years ago, not me personally, but providers were kind of very reluctant to be aggressive with managing and treating diabetes. And we wanted people to try lifestyle modifications. We said, just eat healthy, exercise, it will get better. And to this day, I still hear doctors and pharmacists and providers say this. And it almost makes me cringe and like my skin crawl, because for those who can't succeed on diet and exercise and preventing diabetes, end up feeling like they committed a crime, like they made a mistake, like they messed up, or it caused this to happen to them. The reality is your body is in charge of controlling your blood sugar. And if there's something wrong with your body, we just need to fix it and manage it and move on. It's not as serious as it was labeled 20, 30 years ago. And the responsibility doesn't need to fall on you for getting diabetes because it's not, or not doing enough from your lifestyle changes, because there's so much more to it than just diet and exercise. And so I'm very grateful, to be a pharmacist, to practice clinically in a clinic here where I serve the uninsured patient population. And they are in that boat where they feel like when they come to me in tears, that they just, became diagnosed with diabetes, they feel with this responsibility. And so I'm like I said, I'm in a very nice position where I can come and tell them, hey guys, it happens. Your body gets older, you wear and tear, things happen to your pancreas. And this is a situation that we're in, but luckily we know how to manage it. We can prevent these complications from happening, and we can make sure that you stay healthy for as long as we manage your diabetes. So I just kind of want to put that out there so that burden is alleviated off of the patient, because it's really unfair from a provider standpoint. Then we get to jump right into treatment. So the idea of treating diabetes, and when I say treatment, I really mean managing the diabetes and just keeping it under control. I use the word treat because there's treatment options that we use, but really we're just managing it, keeping it under control. And all of that is in an effort to prevent the complications that were in the previous slide. Now, from a treatment standpoint, there are various types of medications. We have those that you take by mouth, which we call oral agents. We have injectables that you would inject that are not insulin. Then we also have insulins that help manage your diabetes. We mentioned before about type 1 and type 2 diabetes. Type 2 diabetes is where your body may be making some insulin. It's just not going to where it needs to go to be functional, or your body just may not be making as much as it used to. And so we're actually very grateful to have an alternative that we can give to patients to complement what the body normally wants to do anyways. So I'm super excited that we have so much technology. We've advanced so far with our diabetic treatments. And so I'm here to kind of share some of that with you so that you kind of become the expert when you walk into your doctor's office or your pharmacy. You know what you're taking, why you're taking it, and more importantly, you ask all the right questions. Okay, so let's start with oral medications. Metformin is kind of like the drug of choice. Metformin has been around for ages. It is the go-to medication for patients who have diabetes or even pre-diabetes and where it's not contraindicated. So we try to give metformin to almost all of our patients. It actually works in multiple ways to help your body control your blood sugar. That's why we really like it, because it has all of these functions that can actually even help type 1 diabetics, type 2 diabetics, and pre-diabetics. And it's super simple. It's just a tablet. You take it once or twice a day. What people don't love about metformin is that it might not give you that instant result. Like if you're checking your blood sugar regularly and you're wanting to see your blood sugar go down right away, this is not the medication that's going to do it. And unfortunately, when people don't see change rapidly, they think that the product is not doing anything. But like I said, there's so many different functionalities of metformin that it's really important to kind of keep on your medication profile if it's not contraindicated. The other thing that people don't love about metformin is that it causes a lot of stomach disturbances or GI upset. That's the most common. A lot of times we just tell our patients to take it with food, but I'm also here to tell you that if it's non-tolerable to you and you're not able to take it with food because it causes nausea and all of those side effects, there's also an extended release formulation that tends to have a much less side effect profile. And so I encourage you to ask your provider about an extended release formula of the metformin that lasts throughout the day. You only have to take it once a day instead of twice a day, and it's less likely to cause some of those side effects. What I don't want you to do is just to stop taking it altogether, because unless you talk to your provider about it, because like I said, it has so much benefit to it, and so we really need to make sure that it's clinically indicated to stop it if that's something you really want to do. All right, so the other class I have, the next one, these are called DPP-4 inhibitors, and I put both the generic and brand name for these medications. Metformin really only comes in metformin right now, or in combination with other agents, which we'll talk about on the next screen. But the reason I put these in classes like this, in rectangles, is because while it is okay for you to take a medication in each of these different classes, it's not okay for you to take a medication in the same class. So for DPP-4 inhibitors, for example, I'll have patients that come to me and they're on Trajenta and Januvia. Well, that's a no-no, like that's not okay. When you have two agents that are in the same class and you're taking them together, you are increasing your risk for the side effects without adding any benefit to the mechanism of the medication. So I encourage you to be aware of what your medication names are and what class they fall into, because I get a lot of patients who get, for example, Januvia and Jardiance, which is in the next class, confused. And I understand there's a lot of different names, and I don't know who makes up these names and how creative they get and what the process is, if they're just kind of throwing darts at the alphabet and picking drug names. But it is important for you to know what you're consuming and even what they look like. So when you get something different, you can stop and say, hey, this is not what I got before. So that is all very valuable. So these are all the medications: Trajenta, Januvia, Onglyza, and Nicina. These are the ones that are all in the same class. You should only be taking one of those medications if the doctor wants you to take a medication from that class. The next class of drugs is called SGLT2 inhibitors. And before I go on, I wanted to just let you know, I talked about the multifunctional properties of metformin. What's nice about these DPP-4 inhibitors that we didn't know back 20 years ago is that we realized that there's more to diabetes than just the pancreas, and that research led to the development of these drugs. These drugs work on the GI system and help to increase insulin production and utilization in kind of a non-direct way. And so when we found that patients could benefit from these, especially those who are overweight, they developed the first drug. It went great amongst patients, and so that kind of sparked this trend to develop more DPP-4 inhibitors. So I just wanted to let you know that's kind of the purpose of that medication, is we found another avenue to help treat diabetes. With the SGLT2 inhibitors, that was another, research was done. They said, these people are taking metformin, they're taking the DPP-4 inhibitors, but they're still having high blood sugar. Where is this high blood sugar coming from? And they did some research and they realized that our natural mechanism, our body, this amazing, well-oiled machine that we have, its natural tendency is to reabsorb glucose back into your system, because your body thinks of sugar as energy. I need to have energy to think and to work and to play. And so the natural tendency is for the body to reabsorb the sugar that was actually trying to get eliminated from your system. So it's like, no, hold on to that and eliminate, other stuff. So what we found, though, in diabetic patients, we don't want to reabsorb all that glucose. And while our body is very smart from a healthy standpoint, it's not very smart from a disease standpoint. So in a healthy patient, the reabsorption is fine. But in a patient who has diabetes, the reabsorption of that glucose increases the patient's blood sugar. So it's so funny because I get this all the time. People will tell me I didn't eat anything. Like I went to bed, I checked my blood sugar, I didn't eat anything all night. And then in the morning I wake up with high blood sugar. Well, there's a lot of things happening there. Your body produces sugar on its own. It reabsorbs sugar on its own. It's trying to maintain its happy place, and it knows its happy place is not where it has no sugar. So we all like sugar. We all know that's our happy place, and your body is no different. But we did realize that there was a way to give a medication that would help eliminate some of that sugar, not allow it to get reabsorbed, and that really helps tremendously reduce the blood sugar for our patients, even when the DPP-4 inhibitors and the metformin alone is not sufficient. So we love these agents. These are kind of the newer agents, the last two I mentioned, and they are a little bit pricey for those who don't have insurance. There are patient assistance programs that you can apply for if you have low income and you don't have insurance, and those are always available on the manufacturer's website. So if you look on the internet, you look up Januvia, you look up the manufacturer, you'll see that Merck makes Januvia. You look on Merck's website and say, hey, how can you help me get my medication? And they have a program where they'll ship out the medication at no charge if you qualify for the program. Oftentimes, there's also discount cards that will help alleviate the cost. And then if you have insurance, it's nice because at least one of these, one of the medications in each class should be covered on your insurance. But again, if you're having problems controlling your medication, ask your doctor, like, why did you not pick a DPP-4 inhibitor for me? They may say they didn't think that you'd be able to get it on your insurance. They may say, they didn't think it would work for you. But ask those questions about the medications that would help control your blood sugar. The last two classes of drugs are older medications, but I still see them a lot for various purposes. Sulfonylureas like glipizide, glyburide, and glimepiride, those are older agents, and those really help to make your body produce or secrete, have the insulin work better. And so these are good agents. Like I said, they're older agents. What we did find with these agents over time is they have a lot of side effects that we just don't love. Sometimes they will affect your blood sugar too drastically because we don't want blood sugar that's too low either. And sometimes they cause weight gain. And so while you do get results with these medicine, they've just kind of evolved as to being an alternative to the newer agents. For the main reason of cost purposes. Because they're older, they are much more affordable and they're readily available. By no means are they bad medications. I'm not saying they're, inferior. I'm just saying now that we have better options. And so it's really important that if you need this medication, sulfonylurea, they still go ahead and take it and don't come and say, Dr. Eva said that's not a good one, because a lot of patients that can't afford the medication, this is an alternative, and it does the job, because you have to remember the main goal we have here is to prevent those complications. And the only way to do that is to keep that blood sugar low. And so these will do the task. We just prefer other agents because they work in different ways and they don't have the severity of the side effects. The thiazolidine, I'm just going to say TZDs is what we call them for short. The TZDs, Actos and Avandia, they've also been around for a long time. Excuse me. They've gotten a little bit of a bad rep for a while there because it was a thought that they would develop heart problems in patients. We've come to find out that that's not necessarily the case, but they're just not recommended for certain patient populations. But I've seen many patients on them, and they do benefit from them. So I did want to include them because I didn't want to make you feel left out if you are on Actos or Avandia. And I think you may see those in brand or generic. The sulfonylureas you'll only really see in generic or in combination. And the SGLT2s, just like the DPP4s, you'll see those brand names. So Jardiance, Invokana, Farxiga, and Siglatro. There is one brand new, I think it was maybe September, November, I don't know, this whole year is kind of a blur, but it just got approved for type 2 diabetes, and it's called Rybelsus. I'm still trying to figure it out, but it is in a class of medication that we've always known to be injection only. So this year I'm super excited because for those patients who could really benefit from this agent, but don't want to take the injections, now we have our first oral option. So I put that on here also as well, in case it triggers a conversation with your healthcare provider for better control of your diabetes. I hope there's some questions that everybody's putting in the chat box from this slide. There's a lot of information here, so definitely you can ask me any questions and we can go over any of this in more detail. I did want to talk about combination oral medications because it's important to know that if you are taking, for example, let's see here, Januvia and metformin, and then you have a Janumet, you can't take all of that together. Your Janumet is replacing your Januvia and metformin. So I colored the metformin a little bit differently because I really wanted you to see that so many agents use that drug that I mentioned as that drug of choice. It has provided such a benefit to our diabetic population, and so much so that every company that's come along and produced a better, stronger, tougher drug, they've also made a combination with metformin. And what this does for our patients that feel that pill burden, because when you're a diabetic, you have all kinds of medications, not just diabetes medications. You have maybe blood pressure and cholesterol, maybe heart medications. There's a lot going on. So anything they can do to help alleviate your pill burden by combining medications together is just bonus points for you, right? It makes it easier. Again, it can make it a little bit more expensive, but it definitely makes our adherence or in compliance much better. So we kind of have that cost-benefit analysis. And so again, most insurance companies, if they're paying for the single agent, they'll pay for the combination agent. And just like I mentioned with the PAP programs that the drug companies have, just like they have it for their single agents, they also have programs to help assist patients with paying for their combination agents as well. Again, a lot of information here. The takeaway really is I don't want you to duplicate medication. So just know that if you have a Janumet, it already has metformin in it. So I see a lot of patients that were on metformin and then they get Janumet added. Then they're taking the metformin and Janumet, and that's just too much metformin for their body to handle. So really important when you get new prescriptions to ask your pharmacist or ask your doctor, do I take this with the old medications I have, or do I stop taking those old medications? Because it could be that it's a substitute for what you already had. Okay. Now we're going to talk about the injectables, and these are non-insulin injectables. The GLP-1 agonists, Trulicity, Bydureon, Adlixin, and Ozempic, those are given once a week, and Byetta and Victoza are given daily. Now, I did talk about GLP in a previous slide when I talked about Rybelsus, the new oral agent. Super excited about that one. These are the same in the same class as that agent, except these are injectable. And again, so as they're doing research and development on new diabetes drugs, they came across when they were working on the DPP-4 class, the Januvia and those agents, they found that some patients just don't produce enough GLP. And it's actually very common for patients who are overweight and have diabetes, they have a GLP deficiency. And so again, it's like not having enough insulin. We're just so glad that we have the research and development and technology to be able to give an agent that supplements what your body just doesn't do on its own to help manage that diabetes. So these are those agents. These are actually one of my favorites because they help with weight. So they do cause they help people lose weight. And I think they're super simple to inject. They come in really cool pens. So it's not like taboo to be a diabetic anymore. It's kind of like, it's kind of cool to have these pens. You can inject them. You don't have to keep them in the refrigerator all the time, only when you're not using them. So these are kind of things that I like to use with my patients if they're willing to inject. And trust me, if you've checked your blood sugar on your fingertip, you should have no problem injecting a GLP or an insulin because the pain from that finger stick is so much worse than the insulin or GLP injections. So if you have that fear of injection, I encourage you to try to kind of explore the idea if it's something that's going to help your disease, because it's not painful at all compared to those finger sticks on the tips of those, nerve infiltrated fingers there. Okay. So now with insulins. So insulins, in some form or another, have been around for a really long time. They have changed frequently, and they've improved drastically. What I really want you to know from insulins, because it breaks my heart every time I have a patient and they just think insulin is insulin. I'm injecting it, so it must be working. Okay, guys, so I put it on here. Not all insulins are created equal. And I will say it again, not all insulins are created equal. I really want you to understand the different insulins and how they work, because that'll help make you feel better, keep you healthy, actually may possibly prevent you from having super low blood sugar and having a coma, passing out, and also probably prevent you from having really high blood sugar and possibly going into ketoacidosis. So those emergency crises, those are the things we want to stay away from. We want to manage your blood sugar and kind of keep it at this consistent level. So insulins come in different classes, kind of, based on how fast they start to work, okay? Rapid-acting insulin, Novolog, Humalog, Apidra, those work real quick. So within 5 or 10 minutes, they're starting to work, but they also don't last very long. So this is kind of how I like to explain insulins to my patients. Imagine that you have a running faucet, right? So you run the water faucet, and then you turn it off. But say it's not working well, so when you turn it off, it drips. So the rapid-acting insulin is when you turn on the faucet. It's that flow of insulin that's working really fast, and then you turn it back off, okay? As we get through these, we'll talk about the little drip coming out of the faucet. And what all we're trying to do with these insulins that we give patients is we're trying to mimic or copy what this perfect machine, your body was doing anyways. We're trying to copy the function of the pancreas. And what the pancreas does is it drips, like the faucet, insulin all day long, just to kind of keep your blood sugar under control. It's wanting to stay at this nice, happy level. Consistency is what your body likes. And so it's dripping all day long. And then every time you eat sugar, it turns on the faucet. And it says, okay, let me take care of that sugar. And then it turns off the faucet and then drips. And then again, you eat again, it turns on the faucet. It doesn't have to be sugar per se. Anytime you really eat, your body responds by producing insulin to kind of counteract what you ate. So the carbohydrates, the sugars, anything that's not going to be utilized right away, that's what your pancreas is doing. So the rapid-acting insulin is that turn on, turn off. It works really fast and doesn't last very long. So the thing is, if you don't eat after taking this rapid insulin, your blood sugar can go so low, you could pass out. So it's very important that you take it correctly and just as directed by your doctor. And don't substitute it for other insulins unless you've had that conversation with your pharmacist or doctor. The next class is short-acting. So they're kind of similar to the rapid-acting, except they take maybe 20 to 30 minutes to start working. They could last up to 5 or 6 hours. So they're a little bit longer acting, and but they're still short-acting, but they're longer than the rapid. But they work within about 20 to 30 minutes. So if you're taking these insulins and you're checking your blood sugar, don't expect to get a response right away from these blood sugars. It takes about 30 minutes for the short-acting ones and probably about 10 to 15 minutes for the rapid-acting ones. So if that's something that you're wanting to check, you can do that, but they work a little bit differently. So a lot of people that use they used to have it in the hospital, for example, because it's very commonly used in the hospital because it's easy to manage patients on a sliding scale. So they use it a lot in the hospital. But there's people that go home on it as well and manage their blood sugar with it, and they take it with their meals, just like you would take the rapid acting. Except this one is just not as critical to eat right away in the first 10 minutes, but you still only have like a 20 to 30 minute window. So we don't want you to also go too low with by taking your insulin. The next class is called intermediate acting. And so there's a couple things. In this class, we have two agents, Humulin N and Novolin N, that are non-combination. They're just by themselves. But then we also have Humulin 7030 and Novolin 7030. And what those are combinations of intermediate and short acting. So it's 70% of the Humulin N or Novolin N and 30% of the Humulin R or Novolin R. So again, they don't have like a rapid onset. They don't come on very quickly. They last for about 8 to 12 hours. So these are agents that we usually give patients twice a day. It makes it more convenient to inject only twice a day as opposed to 3 or 4 times a day with meals. And it helps for better control as long as you're able to keep your diet very consistent. So these are good agents as well to take, but they're not interchangeable. So you can't take Humulin N and switch it to Humulin 7030 because you're only going to get 70% of what you had in that Humulin N. And I have patients that do this all the time. I'm going to tell you something is better than nothing. I'm not going to lie. But ask your doctor, ask your pharmacist. They'll be able to tell you if you're taking, 10 units of Humulin N and you're going to switch to Humulin 7030, you may need 13 units of Humulin 7030. So that way at least you still get the 10 out of the Humulin 7030. So those are just very important to know that they're not interchangeable. Again, not all insulins are created equal. And then the last class, the long-acting ones, these are Tresiba, Lantus, Levemir, and Basaglar. These are ones that they don't come on. They just kind of like slowly trickle throughout the day. That's when that faucet is just drip, 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 drip all day long, trying to mimic what your body does. And these are taken usually once a day, sometimes twice a day, but for the most part, just once a day. And so that we love them because it increases patients' compliance. All of these, for the most part, come in those nice little pens if you don't want to take the vials. And so you can kind of keep them with you if you need to keep them with you. So they're super easy to take, and they're super effective on managing your diabetes. Okay, so a lot of information here. Oh, I just had a patient yesterday, so last night I said I'm gonna remember to tell my patients this. You guys, I thought I've heard it all, because I'm about to go into patient stories. Just when I thought I've heard it all, yesterday I had a patient and she told me that she had really high blood sugar one day and she remembers taking insulin when she was pregnant. So she went on Facebook and bought insulin, and I never thought I'd hear someone say they bought insulin on Facebook. So I wanted to say this, and again, I have no disclosures, so I'm not partial to this company I'm about to mention, but I'm about to give you some life-saving advice. If you're ever stuck in a situation where you need insulin and you don't have it, you can't afford it, you can't get it, Walmart pharmacies have the Novolin R, the Novolin N, and the Novolin 7030 in the pharmacy, in the refrigerator, and you can purchase them without a prescription for $25 a vial. And I can't say this enough. I feel like it should be on a billboard somewhere, because then at least you can have a conversation with a pharmacist. They can make a recommendation to you. You don't need a prescription. You can get the insulin. You can make sure that it was stored properly, not used by anybody, not expired, and just a trustworthy way to be able to get insulin if you're stuck in that donut hole, or if you've traveled and you've left your insulin somewhere and you need something to manage your sugar. You can get Novolin R, Novolin N, and 7030 at your Walmart pharmacy. Again, like I said, I have no disclosures, so I'm not partial to Walmart. I just know they offer it for $25, but you can get it anywhere without a prescription. But I just know it's much more affordable at Walmart. It's only $25 per vial. And I thank my patient that told me yesterday that she bought a vial of insulin on Facebook for $70. I was like, oh my goodness, you can get this from Walmart and trust that it's working correctly. So I wanted to make sure I mentioned that to all of you today. Okay, so now a few patient stories, and we're going to go through these a little bit quicker so we have time for questions. We're going to start with my mom. So I did tell you guys that this is very personal to me. About the age of 35, my mom was diagnosed with what she thought, well, she was told something about diabetes, but never formally diagnosed and given medications or management. Again, this was a long time ago where the pressure was really put on the patient to, diet, exercise, do what you need to do so you don't have to take medication. It made it sound like medication was the bad apple. Well, fast forward 10 years, she ended up having a heart attack at 45 years old, which is super young these days to have a heart attack. Had a triple bypass procedure. We were in critical care for a week, and then she had to have rehab for 3 months. So it was a very, very complicated process. But I'm here to tell you that, they always say, what is that? There's a saying that says, like, the carpenter's door is always broken. Yeah, so this is my mom. I'm a healthcare person. I am a clinical pharmacist. I'm board certified in diabetes. And I still have this in my family. So I'm here to tell you, like, it's not, like, no one's immune to this disease. It doesn't work that way. She takes 2 oral agents. She takes 2 insulins, which she injects 4 times a day, and she injects a non-insulin injectable. So she's actually injecting 5 times a day. She chooses a lifestyle that's not the best for diabetes. So we do have to manage her medications a little bit tighter. But she is probably the most non-compliant person I've ever met in my entire life. And being my mom, that baffles me. But if she can do it, so can you. That's really what I wanted you to know. If someone like my mom, who's so hard-headed, so, resistant to being helped, and she has all this access, all this information, I can help her anytime. But if she can do it, so can you. And she's able to manage her blood sugar and still inject 5 times a day because she likes her sweets. So I keep her happy, and I just make sure that she takes her medications correctly. The next story I have is I had a patient who ran out of Basaglar, which is one of our longer acting insulins, and she just wasn't keeping her doctor's appointments. She went to use a different insulin from the pharmacy, and she purchased the 70/30. And she took it the same way she was taking the Basaglar. So I mentioned to you guys before that 70% of that dose was working correctly, but the rest, the 30%, was just working for a short time. So every time she checked her blood sugars, they were still super high because she wasn't getting that long-term coverage that her original insulin was. And so that's why I told you guys, not all insulins are created equal. But she did come back and see me in the clinic. We got her back on track. But I want you to always ask a provider first. Tell them, hey, listen, I don't have this. Can I just take this? And they can adjust it for you and tell you how to take it safely so that way you can get the results that you want. My third, I think, last story is the patient who never needed refills. So she was prescribed Lantus in January, and she got 3 vials in January, and she came and saw the farm. Obviously it's a pandemic year, so it's been tough to get back our patients and see them. Came back in June, and I had a televisit with her, and she told me she still has 2 vials remaining. Well, I realized that she wasn't throwing away her insulin 28 days after she starts using it because it doesn't expire on the expiration date once you start using it. Once you start using it, it's only good for a certain amount of time. So I put on here, know your storage and know your expiration date. So very important to know that and be okay with throwing it out because it's not going to work as effective as it should. And so we want to make sure you keep your blood sugars under control. And I lied, I have one more story. I do everything correct. This is my patient who says she didn't want to get in trouble with the doctor, so she told the doctor she takes all her medications every day as directed. And yes, they kind of get like, nodding the entire time. And so the doctor said, well, it looks like her labs came back not, great. It looks like, well, maybe the medicine is just not enough or not working. So what did the doctor do? The doctor increased her insulin. Well, when it came to the pharmacy, I looked at it and I said, well, this patient wasn't even really taking it correctly anyways. Why would you just increase it? And the doctor said, nope. She said she takes it all the time, every day, just like we're prescribing it. So I told her, I was like, I'm sorry, we haven't filled it for her. And I know she's not getting it anywhere else. So I know she's not taking it in a timely manner. And so if we hadn't caught that, the patient could have taken what the doctor prescribed just to try to kind of be good again and be compliant. And then her blood sugars would have been dangerously low. So I encourage you to always, always tell the truth. You're not going to get in trouble. There's no right or wrong answers to our questions. It's really important for us to know the actual status. If you're getting your insulin from your grandma or your uncle or your neighbor or Facebook, tell us the truth, because we'll be able to help you better if we know the full story. Okay, so I talk about goals of therapy. And I put this on here because we take these medications to get to an end result. And while we're trying to prevent the complications, we don't see those for like 5, 10, 20 years down the road. So it's really nice to know that the medications that you're taking are working. And these are different guidelines that kind of set criteria for what we think you should be at to be at goal. Now, every person really has an individualized goal, and I encourage you to ask your doctor, what is your goal? And just know it. Know this is what I need to get myself to, and make sure it's realistic, because I'm not going to say a patient that has a 300 and 400 blood sugar, I need you down to a 70. That's just not fair. So that's going to take some time. So make sure your goals are realistic, and you can kind of work towards the guidelines, the goals set by the guidelines. The fasting glucose is that you check first thing in the morning after an 8-hour fast of no eating or drinking, or you can have water, but no drinking anything else. And you check your blood sugar, and this is the range it should be in. Postprandial is where you check your blood sugar at least 2 hours after food. And we're just trying to see if that pancreas has kicked in that faucet, turned on the faucet with the insulin to kind of work on the food that you ate, or if we need insulin to help your pancreas work better. And then that A1C, that's that magic number. That's going to tell me how much blood sugar is in your system over the past 3 months. It's going to kind of give me that average of all your glucose readings over the past 3 months and really give me a good tell on where we are and where we need to be. So it's really important to know these goals for therapy. Okay, self-care. Like I said, I'm really excited. There's going to be another conversation on self-care in January, so I'm not going to go into too much detail here. I'm going to push you guys to do the basics, diet, exercise, always, helpful, weight control, checking your blood sugar. I think it's nice because it keeps patients involved, and it lets them know that what they're doing, the effort they're putting in, and the medications they're taking are making a change, or they're not making a change, and we need to kind of adjust somewhere. So it's nice to have those blood sugar checks. And you guys, we can't go home with you and check your blood sugar all the time. We don't have you in a hospital, or we can, prick you 6, 7 times a day. So we really count on you to bring this information to us so we can make better decisions about your medications from a provider standpoint. Adherence, medications, they don't work if they just stay in your medicine cabinet or your closet or wherever people keep their medicine these days. So you have to take your medication. They don't work if you don't take them. Really important for you to take your medication, and then also be vocal if you were not able to take them, or if there's something that's stopping you from taking them. Get that blood pressure under control. That'll help, because that's one of the complications or the of diabetes. Keep those doctor appointments whenever possible so we can stay engaged and stay working together as a team. And then really get your mental health right. Sleep, de-stress, all of these are factors that are going to affect diabetes. And I know this year has been a very challenging year for all of us, and it's been a struggle even more for our diabetic patients. So just try to do what is best for you, prayer, meditation, yoga, sleep, whatever it is that kind of helps keep that mental health, because that will affect your diabetes. And my last slide, things to remember. You're not alone. Practice that self-care, because we can't do it for you. I'd love to go home with all my patients and take care of them, but we really want to empower you to take care of yourself. Be that advocate for other people, especially if it's your children or family members, so we can prevent this disease as long as their body will allow it. Listen to your body. If it doesn't sound right, it doesn't feel right, say something. My blood sugars seemed high, or this number that you gave me, this goal was too low. I didn't like the feeling of it. Just listen to your body. This is a very manageable disease. We've been come so far in the treatment options, and so I'm super excited about the data and the outcomes that we'll have and we'll see 10, 20 years from now. And then always ask questions. Never hesitate. Pick up a phone. Try not to use the internet. You can Google if you want, but I avoid that. Try to ask a healthcare expert. There's so much misinformation out there. Ask a pharmacist, ask a doctor, ask a nurse. Pharmacy is easy because they're very accessible. Walk into your grocery store, have a chat with them. I know sometimes they're super, super busy, but just wait a minute, be patient, ask those important questions. And that's all I have for you guys today. This was super fun. I have like 6 minutes for questions. I know I talked a lot, but I hope there's some questions out there.
Yes, thank you so much, Dr. Ebeid. That was really good. Thank you for that informative session, and thanks to all our audience. Thank you for staying on and staying engaged. We definitely have several questions in the chat box, but before Dr. Poon, starts reading the questions, I just want to make our audience aware that we are posting the link for the survey. So please feel free to complete the survey, regarding this seminar, as well as to also give us information on the seminars that we will be having in the future. Okay, so I will turn it over to Dr. Poon for the questions from the chat box and from the Q&A box. Thank you.
All right, we have a couple of questions, and I'm going to read the questions in the order that it has been received. The first question came from Ms. Connors, and she asked, how has diabetes diagnosis changed over time? When my mom was diagnosed, she had several tests, but I was diagnosed by one A1C blood test. I know that few medical conditions have just one test, so I'm wondering why this has changed.
Yeah, that's a very good question. And I did include the diagnosis information in my slides. However, as we evolved and learned more about diabetes, we came across that hemoglobin A1C. That's fairly new, depending on how far back you are. I mean, between my mom and me, that's fairly new because my mom was not also diagnosed that way. And so actually my mom was diagnosed by finding out she had a heart attack. And so we just did not have good means of diagnosing diabetes. We just didn't understand the mechanism of how it attacks the body and what we can pull from a lab standpoint to identify that, until we came across the hemoglobin A1C. And that hemoglobin A1C, that's why she said she did one test, and that's how she was diagnosed. That's going to give us the best answer for what the situation is, because it's got that 3-month record of blood sugar. Whereas like today, if I have a candy bar and I check my blood sugar, it's going to be super high, and I'll think I'm a diabetic, but I'm not. I just ate a candy bar. So that's why now we result to using that hemoglobin A1C, because it's so much more reliable and it gives us that average over the last 3 months. So yeah, changed a lot over the past years.
So another question is, I am pre-diabetic, 5.9. So what diet is available for me?
That's a good question. So there's a lot of factors that we talk about when we decide about a diet, and we're really not trying to push the D word on anybody. We're not trying to say that's a diet. We really need you to commit to a lifestyle change. And so it really depends. I mean, we take into consideration cultural beliefs. We take into consideration, cooking habits, like if you eat out a lot. We take into consideration occupational, issues. There's a lot of factors. So we recommend nutritionists because they really know it forwards and backwards. But, for the most part, we want to, reduce our fats and sugars, just kind of the basics, and try to be more meaningful in our eating, do things that will benefit our body more. But again, it's very specialized, so it's hard for me to answer specifically. I encourage, seeking out nutritional counseling if you're pre-diabetic, for sure, because you have so much power to prevent this from manifesting into diabetes, or at the very least, you can prevent it or delay the onset of that diabetes.
All right, so there are a couple more questions, but I think I answered those in the chat. One last question, and this is from Teresa Waller, and she asks, I would like to know the sliding scale for taking insulin.
Yeah, so Teresa, again, that's a very specific question. It's going to be tailored to your goal, the types of insulins you're taking, and what your blood sugar levels are at different times of day. Again, we spend a lot of time with our patients trying to come up with a sliding scale, if it's even an option, because personally, I don't love it for patients who are not type 1 and not in the hospital, because I just feel like the insulins that we have now do a good job of managing the blood sugar without requiring you to be so involved in the care as a patient. So I like to take the stress off the patients a little bit and give them something that's a little less complex than a sliding scale. But if that's something that you want to do for you, then I definitely encourage you to talk to your provider, look at your goal, look at your insulin regimen, and kind of have that conversation about what's best suitable for you. That is also a very specifically tailored regimen.
I think that's all the questions that we have.
Well, that's perfect timing.
Okay.
Thank you so much.
Thank you. Thank you again, Dr. Ebeid. We definitely appreciate you for sharing your wealth of knowledge with us today. To all the attendees, many thanks. Thank you for joining in. The link to the survey has already been posted in the chat box. Please feel free to complete that survey, give us your feedback about today's seminar, as well as any other topics that you would like us to discuss in our upcoming seminars in the near future. And note that we are giving away $10 target gift card for the first 10 attendees that do complete that seminar survey. Also, a couple of reminders about our upcoming events. January 2021, we have Health Education Seminar, which will be focusing on self-care and resources for people living with diabetes and their caregivers. So several of the questions that were asked, tied into self-care. So please feel free to join us again in January for our seminar. And then in February, we would look at preventative measures in diabetes, where we will bring in the dietitian. We would have a physician also come in to talk to us about some of the practical measures to preventing the diagnosis of diabetes. Once again, I would like to say thank you to all the attendees. Thank you to our guest speaker for today, and to all the moderators. Thank you for helping out to make sure that today is a successful event. And to all the leaders of the Center for Biomedical and Minority Health Research, and the leaders of U College of Pharmacy and Health Sciences, as well as the leadership of Texas Southern University. Thank you so much. Also, many thanks to Mr. Daniel from OIT for helping us on the back end to make sure that our event today has run smoothly. So I appreciate every one of you, and we look forward to seeing you at our next event. Thank you.